It does just reduce the maneuverability of the instrument in the ear. When you've got dead skin like this, you may have seen that I used forceps on a couple of occasions, but the forceps weren't really effective in this case. At the beginning, the wax was a bit too soft and loose, and the forceps just cut into it as opposed to bringing it away. And this, because the skin's so tightly adhered and it's on the eardrum, the forceps just weren't effective at bringing this out. So I've had to put some olive oil spray just to lubricate the canal wall and just soften a bit of the skin. And I'm now just using the fine end. Now, when you're peeling skin, we have to put a lot of force. We have to, I explained to the patient, like double-sided sticky tape. And it's really strongly adhered to the canal wall. So we have to kind of peel it away, tear it away. And to do that, we're having to get a suction grip and then lift the dead skin as far away from the canal wall as possible. But when you've got a narrow ear, there's limited space to work in. So I've just got to be careful, as I don't want to make contact with the opposite side of the ear canal as I'm trying to peel this away with the sucker. So I'm just loosening it all the way around. I'm going to work here to the back bit and to the front of the ear canal in a moment. So when you peel it all the way around, it just gives you a better chance of removing the plug. I did warn the patient that as I was peeling this skin into the centres, I'm trying to bring it into the centre all the way around, that I might block their hearing again, because you can see now, you can see less of the eardrum. I'm folding the skin down and in the middle. I think I'm going to try forceps again. I don't know if this is the moment or it's a bit later. So I'm just going to the roof of the ear canal. Because the patient's ear canal is extremely inclined, I had to look upwards into the ear. So I was crouching down and I got the patient to tilt their head in the opposite direction. So it created an angle where I can visualize the top part of the ear canal. I'm still really just dragging it down. I'm trying to detach it from the canal wall. Underneath, the patient's got a very healthy layer of skin. Now, why has this patient got this thick layer of skin? It could have been as a result of their previous ear infection that they suffered a few months ago. Quite often when you have an ear infection and you've got discharge and you've got some eczema or psoriasis of the ear canal, after you've used some antibiotic ear spray or drops, it crystallizes the outer layer of skin and debris, and almost as it is in this case, it could have been just residue from their previous infection, or it could just be this is a naturally occurring problem for the patient. The skin dies and it sheds and it doesn't migrate and it remains attached to the canal wall. So this skin, if it, for example, my ear, as the skin dies, this is all dead skin, all dead keratin. When it dies, it sheds and it moves sideways out of the ear naturally. And it flakes away, so you have little individual skin cells, epithelial skin cells. But in this case, the skin cells is all the individual epithelial skin cells are attached still, and this skin has failed to migrate, and it becomes oxidized and becomes keratinous. Most of the skin cells in that form the skin in the ear canal, 70% are keratinocytes, which are skin cells that reproduce. So they undergo a process called mitosis, where the cell divides and they replicate itself. And on the outer layer of skin, the epidermal layer of skin, there's 5 layers, and the skin, as it replicates,